We will see you later for the discussion.
Okay.
Vous nous donnez le signal?
Vous pouvez commencer. On peut attendre encore une minute. Les participants sont en train d'arriver.
Oui, on va attendre.
Oui, et il faut sauvegarder aussi. Il faut sauvegarder le audio. Vidéo.
Qui c'est qui fait ça?
Je m'en occupe.
Ah,
oui.
ok.
Et moi aussi, je suis backup. Ok, c'est en cours de sauvegarder. On peut peut-être commencer, Philippe, parce qu'il est déjà 2
oui,
heures
il est 14 et une minute, mais les participants sont en train de se connecter.
Oui, je pense que c'est à cause de mode privé discussion qu'ils ne sont pas réussis.
Ok.
J'attends le signal du maître de cérémonie.
Ok, ben on peut. Je pense qu'on peut commencer. On a 100 personnes. Allez.
Oui.
Ok.
Commençons.
Bonjour à tous, chers consoeurs et chers confrères, chers étudiants, chers auditeurs au sens large. Nous sommes à 2 semaines d'expérience de webinaire au sujet du Covid-19 au titre de l'université. L'idée a commencé au départ par la crainte de devoir former rapidement des forces auxiliaires pour les hôpitaux. Fort heureusement, la stratégie de confinement a permis de contrôler un petit peu la situation sanitaire au-delà de ce qu'on aurait pu espérer au départ. Il fallait donc trouver un peu autre chose pour continuer ce mode d'enseignement auquel on commençait à se faire. Et puis, de toute façon, le confinement ne permet pas d'envisager autre chose pour l'instant. D'où l'idée de profiter de nos relations avec nos collègues en Chine pour les inviter à venir nous faire un retour d'expérience de différentes questions que nous sommes en train de nous poser et pour lesquelles ils ont une expérience qui est bien 3 à 4 mois antérieure à la nôtre. Et bien évidemment, si on compare Luxembourg à la Chine, l'échelle est un peu différente également en termes de population. Nous avons tout d'abord un exposé par le professeur ZhangFan Mao. Et ensuite, il y aura une discussion qui sera animée par 2 confrères luxembourgeois. Le docteur Vic Arndt, que vous connaissez probablement tous, qui est responsable du service national de maladies infectieuses, et le docteur Cyril Tix, qui est anesthésiste réanimateur aux hôpitaux Robert Schumann. Ces 2 spécialités qui ont largement contribué, bien évidemment, à la prise en charge de ces patients. And now we switch to English because the guest of the day, Professor ZhangFan Mao from Wuhan, prefers to give his talk in English. We thank him very much for accepting this invitation. It is an honor for us to have us with us today. And I hand over the presentation of our guest to my new colleague, Dr. Zhangfan Mao, who is working as project manager at medical education since the 1st of April. So she has been very active for 2 weeks, and we have to thank her for all she did so far. So I wish you a nice conference, and we get back to you a little bit later for discussion.
Okay, thanks, Gilbert. As said by you, in close collaboration with the university's International Relations Office. So we have the pleasure to invite Dr. Mao ZhangFan, Associate Professor from the University of Wuhan, Renmin Hospital. Today, he will share with us how he succeeded to achieve the 00 record in the whole battle of COVID-19 with his staff and colleagues in Wuhan. So let us welcome Professor Mao first for today's webinar. 毛张凡，谢谢你，你说我们听 ，please。
Okay. Thank for your invitation. Dear ZhangFan and dear Gilbert Director, I'm very glad to share my experience about how to achieve 00 in the whole battle of fighting COVID-19. I am Dr. Mao ZhangFan. I'm now the Vice Director of the Thoracic Surgery Department of Eastern Campus of Renmin Hospital, Wuhan University. Maybe you want to ask what is 00? 00 means no patient die and no staff infected. First, I will introduction the general information. As you know, the coronavirus is a disaster of the world. That is the pandemic. Many people dead and many people infection. Up to now, about 2 million people infection. So that is not influenza, because the R0 index is 3 to 5. So I must to say this not influenza. First, let's see the picture. We can see this is the coronavirus. Is very similar with the SARS virus. As you see, there is many spike protein on the face of the virus. That is the weapon and it's the sword of the virus. The spike protein can combine with ACE2 protein and then get in the human cell and then copying themselves and then enjoying our lung and production the inflammation storm. So the power, the ability of combination spike protein with the ACE2 is very high. So it's the transmission of the ability is more higher than the SARS. Let's talk about transmission. The source of infection is patients and infected person with no symptom. The routing of the transmission is airborne, droplet, and aerosol and contact. Especially, we often use my hand with our hand to touch our eyes and mouth, but you didn't know. So there is no race difference in the susceptible person. The Wuhan is in the center of China. That it is the traffic center of China. As you see, we can 2-hour flight to all of the important city of China. So they are living 16 million people. When the pandemic happened, our government shut down the whole city. When we look back, I think this decision is very right. All city were in very dangerous. This is our hospital, and this is May campus. Have 3,000 beds by the river. It's very beautiful, yes. And this building it has 500 beds for accept COVID patient. And this is East campus. The whole hospital has 2,000 beds. The government decided to reconstruct the hospital for accept about 1,000 patients. So our department is thoracic department. So we reconstructed the ward for accept 14 patients and just in only 2 days. You can see here is the next station, and after rebuilding, and this is inside, this is outside. We packed the wall with the plank of wood that is fast. So we have 3 areas in our department. Here is the office area, and the bath area, and the patient area. We wearing the protect equipment in the office area, and then go through the buffer into the patient area and do our work. When I finish our work, we come to the buffer 2, taking off protective clothing, glove, and perform distraction, and then go to the buffer 1 and take off the other equipment and change mask and do performing disinfection, and then go to
Dr.
the
Mao, do you hear me? Dr. Mao? Dr. Mao,
yes?
we don't see your presentation. You have to share your desktop because we don't see your PowerPoint for the moment. So it's 1, 2, 3, 4 icons on the left, and you need to share your desktop. Yes, and now switch to your PowerPoint so that we can see it.
So you don't see me presentation? Yes.
No. Yes. Okay. Switch.
Can
you see
just
now?
switch? Yeah. No, you need to switch the window to go to your PowerPoint.
Yeah.
So select another Windows. Yes.
Okay.
Perfect. And now you can put it in screen. Yes. Perfect. Thank you.
Okay. Thank you.
It's okay. Okay.
Perfect.
So continue. Yes. So I continue, yes or no? Excuse me?
Yes, you can continue. We see everything now.
Okay.
Yes.
So here we take off the other equipment and change mask in the buffer 1 and perform the disinfection, and we all have a shower in the office area. So I want to say each step when you do taking off should be very careful and strict. That can to avoid a mistake. We place a mirror in the buffer, or 2 people come out at the same time. So to watch each other to avoid make mistake. If we make mistake, we will bring the virus out in the office area. That will cross infection. At the beginning of the outbreak, our staff is very few. We just have 8 doctors and 13 nurses. So the efficient arrangement is very important to avoid the cross infection and overtime. So I arranged 2 doctors on duty for 24 hours and then take rest for 2 days. And when have emergency and business call, they can call colleague to help. So you can see in the office area we have 4 doctors, 2 on duty, and 1 direct is me, and 1 chief resident, and 2 nurses, 1 for infection control, and 1 is the head nurse. So in the ward area, we have 3 nurses always in the area to care about 40 people patient. With the arrival of medical team from all of the country, the shortage of the staff has been great relieved. In totally 50 medical team support us East Campus. We very appreciate for themselves. At the beginning, I told my staff, I say I hope we can fulfill 2 responsibility. One is serve as a doctor to patient, and the other one is to serve a family member to protect ourselves. So I think they are all do a very good job up to now. No patient die and no staff infect. Today I got good news. Our ward is closed and just have 50 patients in our hospital. So our ward is closed today. The first patient is 30 patient. Let's impress us. Some of them be treated before in the other hospital, and the age from 40 to 93, including advanced age, and some just have the surgery. For example, segmental ectomy, resection, and esophageal cancer resection, and some people is a tumor patient, and many people with the basic disease, that's hypertension, diabetes. We also have the cerebral infarction patient and have Guillain-Barré stay many years in hospital. That is the difficult case. Part 2, we will talk about the treatment and management in our hospital. Here we can see the whole course of the disease. All of the patient is start from here, and symptomatic infection, then to light one, to common one, to severe one, to critical one, and someone death, and someone survival. This is the whole course of the disease. The main symptom including flu-like symptom and gastrointestinal symptom. I think the chief claim is fever and dyspnea and diarrhea. Many patients feel the feeling is from the influenza. This picture is show out the detail of the different type. And when the people infect, if the patient have no clinical symptom and no change in CT, this patient is a symptomatic infection patient. So we should do is isolation at home and mark the patient and follow the patient. We also can give some antivirus medicine. Yes, maybe you can know just observation is okay. And when the clinical symptom appearance, if no change in CT, we name this is light type. In Wuhan, we isolation this light patient in the cabin hospital and give oral medicine. When have change in the CT, someone have clinical symptoms, someone have no clinical symptom, but we think that is meaning the virus is attacked the lung. So common patient we treat in the hospital with oral medicine. If the people has the dyspnea, breathe fast, and SpO2 less than 93%, and the CT group progress more than 50%, that means the people is a bit worse. So we must pay many attention to this type patient, because if we don't stop here, we don't hold the right line, the patient will go to a critical one. As we know, critical type has high mortality, will occupy many medical staff, medical ventilator. So I think we should do active treatment here for the severe patient. Actually, in our ward, most patient is severe patient. So we hold this red line and don't let the disease cross the line. As you see, the information storm is getting stronger. So the influence of the treatment will different depend on the different type. And most patient is the light one and the common one, about 81%. About 14% is a severe one, and 5% is critical one. We can see this is the common type patient as CT sign. This is the feature CT sign is a GGO, ground glass opacity. That is the inflammatory infiltration. And this is severe type. We can see fibrosis, and infiltration, and here infiltration, and consolidation here. So this is the critical type. This patient, we can see, we call this lung is big white lung. A big white lung. We name that because it is very severe infection. You can see here it has the pneumothorax. We put the tuber, and this patient we use ventilator and ECMO support. Actually, at the early stage of the pandemic, many people die when we use the ventilator and ECMO. But this patient, yesterday I got the news. This patient is survival. He can work. So what we should think is how to prevent the progress of the disease, can to reduce the mortality and save the medical resource, even because the patient is too many, and we have so many medical resource. So I think we should hold this line. Use everything, every equipment, every weapon to hold this line. So I want to use 3 anti-therapy here for common style, and use the multi-mechanism therapy for severe patient. Let's talk about diagnosis. That is the feature blood testing. We can see of the coronavirus. We can see the lymphocyte count is decreasing with time, and the dimer is increasing with time. So this is the feature of the coronavirus. This is our hospital nucleic acid test report. We use 2 protein, the nucleic acid protein and open reading fluid lab protein, to make sure the result. Here is the IgG, IgM, and the result. It will help us to judgment which stage and the patient is. An IgM positive after 1 or 2 weeks, then it go to negative. IgM positive after 2 weeks. So if the NAT is positive, IgM, IgG is negative, the patient is in the early window phase of infection. If the NAT positive, IgG, IgM positive, IgG negative, the patient is in the early stage. If the NAT positive, IgM negative, IgG positive, the patient is in the middle or later stage of infection, or the infection recurrence. If all of them positive, the patient is in the active stage. And if the NAT negative, IgM positive, IgG negative, the patient is in the acute phase of infection. If the NAT negative, IgM negative, IgG positive, the patient has been infected before, but now the virus has been clear. If the NAT negative, IgM positive, IgG negative, the patient is in the early stage of infection with very low viral load. If the NAT negative, IgG and IgM positive, that means the patient has recently been infected. So we can judgment from the IgG, IgM, and nucleic acid testing. At the beginning of the pandemic, we have not enough tests to test. So we use the CT to help with judgment. We think CT is more sensitive for clinical diagnosis. GGO is the feature change of the corona numerous infection. You can see here the inflammation infiltration change has no shape and no border. This is the corona virus change. So we must discourage the GGO of the lung cancer because I'm very good at the lung cancer. So you can see here that the GGO has the border and it is circle. This is the cancer cell proliferation, not is the information. So it was quite different. Now we talk about the treatment of the coronavirus. If the people has the clinical symptoms, he will go to the hospital, and we check the CT. If no change, we take this patient light one. Light type didn't require hospital intervention. But I think isolation is necessary. That depend on the national source. So it can be done in the hospital or at home. But my opinion is should be active treatment. We can use 3 anti. 3 anti means antivirus, antibacterial, anti-symptom. Yes, I know. In the past, if I have a cold, I also didn't use the medicine. But now it's different. It's different from the past. So I think we should do some more things active. So we can many medicine we can choose to antivirus, just like HCQ and Abidol. Abidol can available in China and Russia, but not in the Japan or the other West country. And Favipiravir is the Japanese medicine, and I think Tamiflu is more popular in the Europe. Remdesivir, I think many doctors have know the drug. And I like to use the Azi or moxifloxacin to antibacterial, and you can choose the Teflon or Chinese traditional medicine to anti-symptom. So if if it is the influenza 3 anti-serology, I will not choose the HQ. Most influenza will be cured after 3 or after 5 days. Coronavirus infection, I would like to choose HQ, HQ plus Abidol, HQ plus Favi. I think HQ plus AZ is more better choice for the bacterial infection. When there have some change in the CT, some people maybe has clinical symptom, some people maybe no. So here my suggestion is use the 3 anti-serology because that it can help us to prevent the COM1 to turn to the serious type. We can order this medicine with oral. But I think if the change is severe in the CT, we can use some low dose methicillin and human gamma globin. And here is the very important tape because at the beginning, many people come to hospital is the severe type. This type, when the people feel dyspnea, he breathes well fast, and the SpO2 less than 93. So they need oxygen therapy. If we don't stop here, the patient maybe go to critical type. So I think we should use every weapon, every bullet, to every medicine to treat people, to treat patient. This tape to stop here. So I call it multi-mechanism therapy. The oxygen therapy is necessary for this tape, this type. Nasal mask. I think high flow laser oxygen therapy is a very good choice to avoid to use the elevator because the high flow can up to the 60 liter per minute, and we many patient use the high flow because the ICU bed is limited. We have no bed in ICU, so many people we use the high flow oxygen and plus the other treatment. And here antivirus therapy is very important. We can choose HCQ plus Abidol, Favi, or Redisiwe, or Azimid. That will be very good choice. For these people, anti-inflammation storm is very, very important because the storm is bigger and bigger. So we must put out the fire. So we can use monoclonal antibody to anti-TNF or anti-IL-6. We have used. I think the result is okay. But my suggestion is artificial liver blood purification system. This is very good choice for the anti-inflammation storm. At the same time, we use the low dose methicillin to reduce the infiltration of the pulmonary. And we also use a human gamma globin to strengthen the immunity for the elder people. At the same time, we should treatment and control the basic disease, like that is also important. When the D-dimer is high, we will give some anti-coagulant. And when the IgG less than 100, if we have, we will use the blood plasma of a recovery patient. When people turn to critical type, that is very dangerous. In all of the world, American or Euro, Italy, that the mortality is very high. Actually, it's not the best time to use the antivirus drug. We should use antivirus drug before. But if many drugs that receive can't effect 100% because the patient here is not just virus, is just have the anti-inflammation storm. That is the key point to for the patient. And at the same time, we should support the breath and the circulation. Most of people need ventilator support, and some need ECMO support. When the patient is the severe type, it's very complicated. Many things we should care about. Actually, I am not the doctor in ICU, so I have no many experience about this, but I know that is very complicated. That is why the patient occupy the medical resource, and why the mortality is high. So that is our suggestion for the patient isolation. For the suspect patient, we should provide separately area with masks, with single room. Keep at least 1 meter distance between suspected patient and the other patient. We also should teach the patient how to cough and sneeze. Cabin hospital, I think that is a good decision because most of the patient is gathering together, and so no the infection in the society to transmission, and we can treat and observation this patient in the cabin hospital. This is my colleague. When the cabin hospital is closed, he is very tired. That is the protection of staff. I think to avoid the cross infection, we should do the 5 protection. First is physical protection. We should provide good equipment, and psychology protection is also important, because everyone, every staff first feel fear, depressed, anxious for long time work, and the medical protection, I think if we have, we can give. We use the Chinese traditional medicine, and use the Abidor and use the HCQ to prevent. And the knowledge production, we should give a good knowledge of the coronavirus. And that is the arrangement protection. We will let our staff know clothing and have a good rest and no tired. So that is my experience. Here is our dining room in the office area. As you see, it's here, and the distance is enough for us. And we also do the air sterilization machine. Actually, at the beginning, we have no many choice to antivirus. Up to now, as we know, we have this choice. The railway is not finally finished. It's affected, but not the specific drug. HCQ, I think this is our hope because it's cheap and it's effective. And arbitrarily just available in China and Russia. That this is very safe medicine. We can use for months. It's no problem. So I think, but some people effect, some people have no effect. So I think this is a good choice for the early stage of the disease. And Lotilavi, we have used, but I think that just has limited effect and had a side effect. At the beginning, we use Abidor. If have no effect, we use the Nopinavi and the Lotinavi. And the Favi have the trial in our hospital, and we see it seem more effective. I think it will be a good choice later. Now let's we talk about our hope, HCQ. HCQ can anti-inflammation, storm, and antivirus. I think the antivirus the effect is more important. As you see, he can describe the cytokines, and as you see, the HCQ can prevent the virus from binding to the cell and entering the cell and recopy. So we can imagine if we take some HCQ, the virus, coronavirus can't combine with our cell, or that will help we reduce the virus. This is very famous trial by French scientist. He uses HCQ and AZI. Actually, this is antivirus and antibacterial. At the same time, AZI has the antivirus effect in vitro. So I think it's a good choice. So my suggestion for HCQ is HCQ plus the arbitrary because the antivirus mechanism is different, and so we can combine the two drugs, arbitrary or Vavi relatively. I think the data is here. 0.6 for 5 days and 0.4 for 5 to 10 days. And I think HCQ plus RZ will be a bad choice for the mixed infection. But we should pay attention to the QT interval cardio risk. HCQ is safe for 5 milligram for long time use. So if we early application and HCQ may help us to produce antibody because it can reduce the virus and get in the body, but the very small volume virus getting body will help us immunity product the antibody. So for the close contact person, I think it may be effect as a preventive medicine. The artificial liver blooding system, I must to say, because it can rapidly remove the inflammatory matter and blocking the cytokine storm. We use that in our ICU and achieve high success rate. So the mortality in our ICU is about 20%. Yes, it's about 20%. The mobility in our ICU. So you can see this patient. I have mentioned before. I think the artificial liver is the key point for him. Now I will give you a case report. This case is the beginning case because in the beginning we have no experience, we have no many drug to use. So I think is very typical. And the patient is female and 65 years old, and on the 7th day's course disease, the patient was admitted to the hospital, and the chief complaint is fever and cough. In the 3rd day, the nucleic acid test is positive, but the patient has no exposure history of the COVID-19. When he come to hospital, we check the SpO2 just 93%. So we diagnosis this is severe tape. Let's see the tape. You can see we first use the oxygen therapy. First use the face shape, and then use the layer nester. The WBC is always normal, but the limbus cell is here is limba is this cream, and when he leave the hospital, the limba is recovery. CRP at first is high, and the PCT is higher, and so we use the moxifloxacin for the antibacterial for 7 days, and we use Abidol to antivirus for 5 days, and because she is 65 years old, we also use the human globin for 5 days, and the change in his CT is severe. We also use very low dose per decino for 3 days. And the nucleic negative on the 20 days. In our hospital, we should twice negative. The patient can leave hospital and to the isolation place for another 2 weeks isolation. And you can see the CT. This is the first day in hospital, and after 5 days, multi therapy, the CT is better. But it from here to here is takes a long time to recovery. So I think the first 5 days treatment is in fact prevented the further development. But as you see, the fibrosis of his lung, the recovery is slow and need 2 weeks. So I would like to compare the Wuhan patient and with the Mr. Boris Johnson. He is the primary minister of United Kingdom. I see the information from internet. We can see the first day Mr. Johnson isolation at home, and he is the light type, and the 8th day the Johnson had fever. He also stayed at home, and he is the I think it's common type. And 10 days Johnson feel dyspnea, so she need oxygen. And when the doctor gave he oxygen, he feel better. But just one days later, she go to the ICU because maybe he need a ventilator. So we can see most Wuhan patient and Johnson is almost the week 1 week come to the severe type. So I think if the Johnson have the 3 anti-therapy here or here, maybe he will not go to hospital or he will not go to the ICU. The Wuhan patient, if we don't hold this line, we don't use the multi mechanism therapy, maybe the patient will go to the critical type. So it's in the case of difficult to distinguish between the influenza and the coronavirus. So I think we should anti-influenza treat first, use the oral medicine. If after 3 or 5 days later, no improvement or the patient dyspnea, we should scan a CT for the patient and do the nucleic test. But now we have if we have enough nucleic tests, we can do the nucleic test first. But at the beginning of pandemic, we treat the people like this. So as you see, we can do the activity treatment when the people is the symptomatical infection. We can use the antivirus. When the patient is light or common, we can use 3 anti-serosp. When the patient is severe, we can use the multi-united serosp. When the patient go to the critical, we must perform life support. We can use the HCQ all of the disease cause. Actually, later of the recently, we in our world we treat the long-term no turning negative or and recurring positive patient. I found most of them need no oxygen and no symptoms. Most of them stay in the hospital for 2 or 3 months, and many of them has basic disease, stage 4 cancer, kidney transplantation, and I also found someone nuclear positive, but the IgG level is high. So I think maybe for this patient, what we can do is just wait. So in this patient, the inflammation storm has passed. So the HCQ seem limited effect. We have tried HCQ plus Abidol, Favi, Azi, someone effect, someone no. But I think the blood plasma of the recovery patient seems effect for those patient IgG level is low. We also can use some Samosin and Chinese medicine. And I must to say we should pay attention to the psychological state of the patient, because the patient leave his family in the hospital for a long time. I think a symptomatic person, we should do isolation and following and protect himself and the contact person. And I think we should perform active oral medicine, and that may be a good choice. Recently, we treat a patient that the patient is a symptomatic patient. I use HCQ plus Abidol. Yesterday I checked the result. The nuclear test is negative. That means I use HCQ plus Abidol for this patient for 5 days. The nuclear result is negative. So about the restart of society, my suggestion is should after the peak pass in the Europe. I feel coronavirus toxic is weakened after several generations, because we at the beginning the people many patient is severe type, but now seldom of them is the severe type. It's just a common or light one. And we also can restart with the relatively isolated work. For example, the medical staff, doctor and nurse, we just apartment hospital. We contact the relatively fit population. So we can work, but we are safe. And I think most population of society must realize the importance of the protection. That means we must wear the mask. And this point is a very interesting point. apply little does HCQ for prevention and blocking the transmission in the community. So let's see a video. In this video, we can see why we wear the mask.
0.1 マイクロメートルの粒子まで捉えることができる世界最高水準の技術です。実験開始。まずはくしゃみです。目に見えるのは直径1ミリ程度の大きな飛沫。すぐに落下します。ところが、高感度カメラで見てみると、
Japanese scientists do very good job. They help us see the very tiny particle.
のは至近距離での賑やかな会話。大きな声を発すると、たくさんのマイクロ飛沫が発生します。二人の間で漂い続け、なかなか消えません。この研究室では、密閉空間でのマイクロ飛沫の動きをシミュレーションしています。教室ほどの広さの密閉空間に10人程度がいるというケース。一人が一度咳をしたという設定です。およそ10万個、大小様々な飛沫が広がります。青や緑で示した大きな飛沫。これらは1分以内にほとんど落下します。しかし、赤色で示したマイクロ飛沫は空中を漂い続けます。マイクロ飛沫だけでシミュレーションします。5分後、10分後、少なくとも20分。マイクロ飛沫は空気のよどみで漂い続ける可能性が明らかになりました。レーザー
And this one. Okay. Actually, I am a surgeon of thoracic surgery. Actually, I am good at the mini invasive thoracic surgery. And you see, I do the 2 cm for the lobectomy, and I call it the super single port. We don't use the electrical light, just use the clamp to blunt separate. So you can see here is just 2 cm, and we finish the lobectomy and pull it out. And actually, we was use just 1 cm to perform the lung cancer resection for young women. I'm very thanks for your invitation to give my the chance to share my experience. I hope we can help each other, and because we are all human beings, we face the same enemy. We will victory as us. Thank you.
Professor Mazard to introduce our guest from Seychelles and Hospital Robert Schumann. Thank you again, Professor Mao. So it was really very interesting. So now, yeah, I can see Dr. Severe and Dr. Week. So we are very happy today to have you in our roundtable discussion. It seems that Professor Mazard is not here anymore. So I will just make this transition. So we are very happy to have you both here. We have never worked together before, but I learned from internet that you are specialized in the infectious disease. So this is for Dr. Wick Ahand, and Dr. Cyril specialized in anesthesia and resuscitation from the Hospital Robert Schumann. So now it's your turn if you have some questions for Dr. Mao. So I will be here to give my support. And also there are some interesting questions from our students. We can also pick up some of them if you want. Yes, please.
Okay, I will start by thanking Professor Mao for this really very enlightening presentation. And there has been so many questions to ask, actually, so it's a bit difficult to decide where to start. So when I see your evolution from mild cases to large cases with no pneumonia, common cases with pneumonia, and then severe pneumonia, critical cases, my feeling is that our attitude in Luxembourg, on Europe in general, is always one step behind your attitude, because you propose to start with antivirals very early, in mild cases, even without pneumonia, as opposed to us, where we keep the antivirals for patients needing hospitalization, which is already we have criteria of severity. Can you address that point, please?
毛张凡那个教授的问题 ，Wick 教授的问题就是说，在严重的新冠肺炎的病人当中，卢森堡的那个治疗方案好像比中国的那个治疗方案要晚一步，就是你是首先上抗病毒的治疗，对吧？他们这边的话是在非常晚的阶段才用，他想让你把那个标准诊疗标准再说一下，就是什么时候用抗病毒，什么时候用其他的药物。So maybe you can repeat again. You have already mentioned in your presentation the criteria how to use different drugs for severe type of pneumonia. So maybe you can repeat again and go into more details. Yes, please.
Okay. As you see, I think we should use the antivirus treatment more earlier because in the late stage of the disease, the injury mainly caused by the inflammation storm. So you can see the RCV is seems no effect in the critical patient. But I think if we use the RCV more earlier, maybe it will affect. Actually, including Favilavi Lotilavi.
I've seen in your presentation that hydroxychloroquine monotherapy you basically use only for very early patients, and after that you use at least the combination of HCQ plus either Arbidol, which is unfortunately not available in Europe, or Favipiravir, or maybe Lopinavir. So dual combinations. Can you comment on that? So even patients with mild pneumonia, which in Luxembourg we would send home without any treatment because those medicines are limited to hospital use, you would already use 2 different antivirals. Is that correct?
毛先生，他有点延迟，我听得不是很清楚。
没有，所以这边的话，他们对于轻症的肺炎病人，就是在家里没有什么特殊的药物。然后重症的话，就是因为他们有些药没有，所以你这个再跟他们解释一下，这个用药方面，如果没有你药怎么办？
对。
Yes, I just explained.
So you mean you have no Arbidol? Yes, you have Tamiflu. Yes. I don't know which antivirus medicine you have in Europe. I think you have Tamiflu. Is it right?
We do have hydroxychloroquine. We do have Lopinavir, interferon, ribavirin, Tamiflu is available, and we hope to have Favipiravir maybe in a week or at the latest 2 weeks from now. But Arbidol we do not have at all.
Yes. Actually, I don't think Arbidol is more better than Favipiravir. I think Favipiravir is okay for the influenza or for the coronavirus, but we should use when the patient just is light or common type. Because if the patient is severe or critical type, it's not the best time for the antivirus medicine to work.
So there are questions from the audience about should patients who have a CT scan performed early and have lesions on the CT scan, should they be hospitalized always? Any patient with lesions on the CT scan, should he stay at the hospital?
对，就学生里面有一个问题，那个问题就是说，如果是否需要早期就做那个 CT， 然后这些有损伤的这些患者是否应该早一点收入院里面 ？OK？
对 ，Yes. Yes, I think we should scan the CT for the patient for early stage because you can see many people when he come to hospital he feel dyspnea, but now it's very severe change in his lung in CT. So this virus is different from the other virus infection. This coronavirus infection is for some people is more faster to the severe. So that's why I say we should have the actively treatment earlier. If we use if the people lose the chance, because I think is with the disease progress, that is the virus copy and in from machine storm bigger. That is the progress. So in our experience is should do something early and activity, not just observe at home. Do nothing for the patient.
Thank you. Maybe I will leave the questions regarding intensive care and intubation, ventilation, and anti-IL-6 therapy to my colleague Dr. Tix, who is an intensivist.
Yes, thank you. Thank you, Vic, and thank you, Dr. Mao, for your presentation. I think we have the chance in Luxembourg to have had countries ahead of us. So we had a couple of weeks to see what is going on and to prepare ourselves, and also to do the lockdown of the economy quite early. So now, after 4 weeks of economic lockdown, the situation in Luxembourg is not as worse and as bad as in France or in Italy. And but nevertheless, we have also reduced our non-COVID medicine part. And my question would be, how did you manage the normal medicine treatments and diagnostics during the COVID epidemic, and also now that the epidemic is over? Because there's also a risk that there's a secondary sanitary crisis in the non-COVID medical part.
OK，毛大凡这边，卢森堡这边已经封城，就是已经有1个月了。3月16号这是封城的。然后这边的话，这个Syria 医生他的主要问题就是我们怎么在收治COVID-19这个病人的期间，也治疗他其他的基础疾病。因为我们这边收治的病人他也是年纪特别大，有一些其他的疾病。那你在收治过程当中怎么去跟其他的疾病去进行区分，然后同时治疗他的疾病？ Okay, please.
Yes, I think that is a very good question. Actually, in our city, we do the treatment for the coronavirus, but many patients with the other disease have enough medical care. That is a question. But if we have enough test ability, we can test the patient first. If the patient not corona patient, it can go to normal hospital. And if the patient is the corona patient, we gathering the patient in one hospital and treat the coronavirus infection and the basic disease the same time. I think it's not a struggle because corona virus for many old people that is very cute. I think it's acute. It's acute disease. So we should treat the coronavirus first, and at the same time control the basic disease. Actually, we don't do the operation during the corona infection pandemic. We just do the emergency case. But for example, lung cancer we don't do. But if the bleeding in the chest, we will do. Like deliver of women deliver we do. But we all first test the patient if have the coronavirus or not.
And so is it a screening which is clinical and also by testing? Do you test the PCR, so the nasal PCR, and also the immunoglobulins in every patient that is coming for the non-COVID medicine? What is the screening to be sure not to get a COVID patient inside the non-COVID medicine? How do you separate both pathways?
你们这边是如何区分非新冠和新冠患者？你们是所有进来看病的病人都会做一个鼻咽腔的这个刮片的这个 PCR 加上血清学的检查，还是怎么样？是普查，然后区分，还是有其他的特殊的方法
？Yes. Because we have the lesson at the beginning, many people go to the hospital. The hospital very crowded, so one trans to the other one, and the one patient trans to the doctor. So at the beginning, many doctors affected because all the people come to hospital without test, and we don't wear mask at that time, so many doctor infected. So now we and the number of patient in Wuhan now is just maybe 300 patient now. 300 patient, 300 coronavirus patient in Wuhan now. But we every people, every patient come to hospital, we must test his CT scan and blood testing for antibody, and test for nuclear 3. CT, blood testing, and nuclear test. If both okay, the patient can go to the normal hospital. If positive, the patient go to its campus or next hospital, its campus. The government say you to which hospital by the government.
Okay, so the answer is yes. So besides the 2 tests that Dr. Cyril suggested, so in China we also use the CT scan to fully understand if the patients are positive for coronavirus, and then it's the local government who decide if this patient should go to this hospital or should go to another hospital for the further therapy. So there is a protocol in national side. Okay.
And how was, in your experience, the switch between a patient that is in the normal ward and then has to go to the intensive care? Did you have the time to check for the necessity, or has it been very acute, so you only had a couple of minutes to react, or did you foresee the worsening of the condition?
就是你们发现这个病人需要立即转到重症监护室的话，你们这边有没有一个特殊的一个程序？因为有时候病人这个发病会非常的快，可能几个小时、几分钟，你们这边有一个特殊的程序或者一个流程吗 ？Please.
Yes. Yes. If if the patient is have the life dangerous of losing his life, so we treat the patient in the hospital where the patient go to where the patient go, and when the patient is stable, the patient must go to the East Campus hospital like us. Actually, in every normal hospital, they will have a ward for the patient like this. This means the hospital is not treat the coronavirus hospital, but the hospital also has the area for the patient to treat first, and then go to the hospital government order. 我说清楚没
？The intensive care， 所以我们如果要把它转到重症的话，那么这个就是在同一个医院里面需要转的话，你们这边有一个特殊的流程吗？就是说在本医院转，不是转到其他的医院。I think the question is like this: if we need to quickly transfer the patients, if you have some special measure or protocol to share， 你明白我的意思吗？
我们是先把病人情况稳定了以后，然后再用救护车转。但是每个医院就是非定点医院，我不知道定点医院怎么说。非定点医院的话是有一个区域专门收治这种病人的。
Okay, so in fact, in China, in Wuhan, they have a special area in each hospital to quickly hospitalize the patients in the critical situation. So they have an ambulance to quickly transfer these patients. So in each hospital, they have a special ward for this. So no need to waste time or transfer to another hospital. Yeah. I think is this. So at the beginning, when the patients enter into the hospital, they try to stabilize the situation, and then if there are some emergency, they quickly give measures locally. Yeah. So this is what I understand from Professor Mo.
Mm-hmm. And to come back to the treatment, indeed for the patients that are hyper-inflammatory. And I think that these are people that need to go to the ICU quite often. And do you know what are the results with the treatment of anti-interleukin-6 treatments with monoclonal antibodies? What is your experience in this domain?
你们用那个单抗，就是炎症病人比较严重的时候，用单抗和那个抗百吉六，你们的那个治疗效果怎么样？ So please introduce a little bit your experience on this.
Actually, the 单抗怎么说？我
mono antibody for you use mono antibody.
Yes.
Antibody, yes.
It's the monoclonal antibodies you can use.
The
yes.
You know, for the cytokine storm treatment, for instance.
The tocilizumab.
Oui.
就是你们把你用的那个药的。
What are your criteria to decide when to start the patient under tocilizumab against as an anti-IL-6 therapy?
对你那个单抗。
IL-6.
Yes.
The question is about the cytokine storm that some people may have.
就是发生炎症风暴的时候。
对，妥珠单抗，我不知道这个怎么说，妥珠单抗。
Yeah, he has a special name for this antibody, and he just look for you. But you can explain the strategy. 你可以把你们那个策略简单的介绍一下，就是。
我敲出来上了。
Yeah, so he will try to use the chat to give us the name of the antibody.
Maybe in between, I can ask one other question that has come up several times in the audience. It is about preventive use of hydroxychloroquine for people with underlying conditions, elderly people, and also for healthcare workers, which you have suggested using hydroxychloroquine as a prevention against infection for healthcare workers and maybe also people in the general population with underlying conditions.
羟氯喹的预防作用，你可以简单介绍一下吗？就是可以给正常人群或者是医护人员作为预防用药吗？
可以的。First, we know those patients who use HCQ for long-term cell infection by coronavirus, SLE patient. SLE patient use the HCQ for a long time, but they seldom infected. Yes, and I think HCQ is safe for long time use. So when we use for a short term, that is also safe. And we know the mechanism of its antivirus is stop the virus entering the human cell. So if the virus can't get in the human cell, she can't copy and he can't survive. So there's very few virus we're getting in our body that will help body produce the antibody. So I think we can use the drug for the people who close contact with the coronavirus infection patient. And at the same time, it have no harm to us. I would like to use about 0.2 one day for 1 day, and if you have the close contact with the infected patient, I will take 0.2 for 1 day and for 5 days.
0.2毫克还是0.2毫克 0.2 milligram.
That is one tablet of hydroxychloroquine.
Yeah. Okay.
1 pill.
1 pill. Okay. I saw also there's another question concerning the plasma therapy for as an option for vulnerable people or clinical staff. 毛大凡，你就是那个血清疗法，你有没有什么建议？ So if you 血清疗法 plasma therapy, if you have some ideas on this.
Yes. I think plasma therapy. Yes, plasma therapy we have used for many people because you know there is many recovery patient in Wuhan, so we have many plasma to use. I think if the IgG less than in our hospital, if the IgG less than 100, IgG less than 100, we will use. But at the same time, we must pay attention to the plasma injury on my lung. We observe some patient have the acute lung injury by plasma, and at the same time, I think plasma we can use in the people who is long time can't be negative. We once used the plasma for a kidney transplantation patient.
So you mean patients that are not able to get rid of the virus by themselves for a long period of time, you would give them convalescent plasma. Is that right?
就是他如果这个长期的其他的3年疗法没有效的话，那么你这边就是给血清疗法进行处理，对吗？就是作为最后的选择，还是一刚开始就上这个血清疗法？应该是一刚开始有抗病毒、抗炎症和抗细菌吧？
最后选择，对。
Yes. So he used at the end if the 3 anti-therapy doesn't work. Yeah.
And one other question from the audience is about the artificial liver therapy. How accessible is that treatment in your city?
就是那个人工肝的那个方法，在武汉的那个使用情况是个什么样子的 ？Artificial liver therapy.
对 ，artificial liver system. Yes. Artificial liver system. I heard about just used in just a few hospital. Our hospital, because we have a doctor very good at use the artificial liver system. That doctor is also a infection doctor. 感染科的医生怎么说？是吧
？Infectious disease. So the health worker in the infectious disease. Yeah.
Yes.
So
我说清楚了。
So they use this system more than the other. 你就说感染科的医生用这个用的多一些吗？
对，因为刚好跟我病区跟我一起合作的一个医生是感染科的医生，他非常善于用这个。
Ok, oui, professeur Mao, il a dit que les médecins dans les blocs de maladies infectieuses est très doué pour utiliser ce genre de système. Apparemment à Wuhan, et les médecins à côté de son bloc a commencé à utiliser en premier et maintenant il maîtrise beaucoup et il a introduit à professeur Mao et lui, il a trouvé que ça marche très bien. Voilà, c'est son expérience un peu particulière. Oui. Je ne sais pas, au Luxembourg, est-ce que c'est la même chose, docteur Vic, ou vous avez expérience?
Je vais passer la question à Cyril parce que chez nous, en maladie infectieuse, on ne gère pas du tout ce genre de technique.
Ok.
Yes, it's a technique that is being used in the ICUs, but in Luxembourg we don't have this method of liver pour remplacer la fonction hépatique et pour épurer le sang. So we don't have this mass technology and equivalent methods. Yeah.
And in the labor countries, in Germany or in Belgium, we have this. Yes. Okay.
Yes, it exists in university hospitals. It exists, but it's more an experimental approach than it really being used on a regular basis.
OK， 现在卢森堡还没有这个系统，其他国家有，德国可能有。
没有人工肝是吧？
没有人工肝的那个系统，对。So maybe we can't hear you, Dr. Witt.
Okay. I wanted to ask a last question about lung fibrosis.
Yes.
You have mentioned several times during your presentation on the CT scans the degree of lung fibrosis, but do you have data? Have you quantified the lasting damage in the lungs of these patients? How important is this this fibrosis, and how permanent will it be in these patients?
麻烦反正他就是说你在那个病人 COVID 的那个病人上面展示了他有那个肺部纤维化，然后炎症渗出，还有那个就是硬化。那你有没有就是大的数据，就是定量的数据，就是可以分享一下 ？So please.
I'm sorry, I have not quantified research. Because we have no time to do the research like this. But we found many old patients have the very severe fibrosis in lung, but many young patients is not. Young patient, the filtration is domination. So I think it doesn't matter with the immunity and the quality of the lung, because young patient lung is fine, so the inflammation is stronger, so the infiltration is severe. But the older patient, his lung, as you know, the many cell maybe apoptosis, and they have fibrosis already. So I think it's just like the fresh orange. You can push the juicy, but unfreshy the juice you can't many juicy. So that is my feeling.
Okay, I hope the answer is.
There's another question also from the audience. What is your position to invasive intubation versus non-invasive ventilation and nasal high-flow oxygen delivery? Do you think that these non-invasive methods may help some people to get around an intubation and an ICU admission? Did you use it a lot in your ward?
在你的病房里面，那种侵入式疗法就是增加那个氧气交换、气氧交换的那个比较多，还是那种非侵入性疗法多一些，还是侵入性疗法多一些？他们主要这个是减少对病人损伤。So it's long-invasive method. Okay,
yes,
is the first long-invasive.
We use the high flow nasal oxygen.
Okay. So it's less harmful for the patients. Less harmful. And it's also efficient. 有用吗？就是效果什么样？
Yes, it's very good.
The risk for the workers is that they get contaminated because you have much more aerosols that are being out in the air. So how long did you keep on the personal protective equipment? Did you keep it on for 4 hours, for 8 hours? Because I've read that you are on 24-hour shifts.
因为这种非侵入性的疗法的话，那么这个就是医护人员受感染的情况要多一些，因为那个病人的呼出来的气体，这个暴露的比较多一些。那么你们在给他治疗的时候，会让他使用多长时间？4个小时、8个小时、12个小时 ？How you manage？
不是吧？侵入性疗法会这个一点。 If need a ventilator, the patient will transfer to the ICU. We have we seldom to use the 气管插管怎么说 tracheal
So the incube. Okay, so the invasive method for him is more dangerous. He don't think it's a problem. Yeah.
And because the personal protective equipment is quite it's quite hot, and it's not easy to stay with this equipment for long hours. How did you manage the healthcare workers? When did they get a time off? And how many suits of PPE did you use per shift?
对，就是你那个，就是你们的那个，工作人员，你们是怎么调整休息，怎么保证每个人都不感染？然后 PPE 那个应该是防护服吧，个人的那个防护服，你们每个人有多少防护服、防护设备？ So yeah, how you protect your staff? The second zero.
We have enough protective clothing and mask. We have enough. So that's
and how many,
question for.
And how many in average you use per staff? Just to have an idea. Yes. 就是大概每个人会用多少每天？就是我们有一个概念。因为你说你们有很多，因为我们这边不够 ，because we don't have enough here, so we need to very well calculate and use it in the most efficient way. So this is the question, I think.
大概我看看啊，大概每天有10套吧，10套吧。
一个人有10套。
不，一个人1套，一个人1到2套。
OK. Chaque jour, ils ont 2 équipements par personne. Chaque jour.
Ah, ok. D'accord, c'était ça ma question. Okay.
Ouais, ils ont 5 staffs qui travaillent ensemble et ils ont 10. Et du coup, en moyen, c'est 2.
Et c'est sur 8 heures alors ou...
Toute la journée, 8 heures de journée de travail. Heures de travail. Après, s'il reste... Après, normalement, ils ont un horaire par personne pour éviter que tu sois trop fatigué. Voilà.
Dr. Mao, since you are a thoracic surgeon, and since there have been many thoracic CT scans performed in the last months, did you notice that more lung cancers have been found, and that you have more thoracic surgery activity in this domain?
你有没有发现新冠肺炎爆发以后，有更多的就是肺肿瘤的病人、肺癌的病人出现了？然后你在这方面有没有什么感受可以分享一下 ？Please.
Yes. Actually, many our colleagues always ask me to watch his or watch their CT because they found pulmonary nodules in the lung. So many people find.
So it's the cancer patients for lung. So they ask you to help them distinguish between COVID or long COVID. That's right. 就是让你帮他们去区分。Okay, yeah, it's interesting. So it's a teamwork.
I had one last.
Okay.
One question by the audience about the value of IgA testing compared to IgM testing. I understand IgA also for early diagnosis, acute phase diagnosis. The slides you have mostly mentioned IgM and IgG. So we have an opinion about IgA versus IgM antibodies.
毛张凡在那个血清的那个诊断里面，就是现在我们用的是 IgM 和 IgG 的，就是双抗的那个检测。那么 IgA 的那个检测有没有就是考虑到，或者是在这个里面你觉得没有什么必要
？IgA
？Yes， 因为我们有 IgA、IgM 还有 IgG 嘛，就是3种免疫球蛋白。你觉得这个 IgA 这个那边有没有检测？
No, we don't test IgA. I just test IgM, IgG. So I don't know.
Okay. In my understanding, for mucosal infections, IgA are probably more or less equivalent to IgM, but
yeah, maybe for the COVID-19, it's not the most significant marker. Yeah. Okay. Do you have any other questions? We are nearly 2 hours until now. Yeah, everything goes fine. So first of all, I would like to thank you, Professor Mao. 毛张凡非常感谢你给我们做了这个讲座。So thank you very much. And also great thanks to our 2 guests, Dr. Wick and Dr. Siria, for your questions. So very interesting discussion for everyone. And we try to answer questions from audience as well. But if there are still questions, we will answer by email if you prefer. And also, you can also send us email. We will try to answer and transfer to Dr. Mao for further follow-up. Thank you for this webinar. I would like to check if Professor Mazad has still something to say. Yeah.
Okay.
Yes, I think
it works. Marvelous.
Yes, it works. Yes, please.
Well, I can only echo what you have said. First of all, wholeheartedly thanks to Professor Mao, who is not only a brilliant thoracic surgeon, but also a brilliant infectiologist, as we mentioned now. And many, many thanks for the report of experience, which is absolutely interesting for the medical community of our country. Thank you to Vic and Cyril for animating the discussion. Thank you, ZhangFan, to be the link between Luxembourg and China.
You're welcome.
And thank you to the audience who stayed at the level of almost 100 up to the bloody end. We hope that we will meet soon again for the next Sino-Luxembourgish conference on COVID-19. We have an event that is scheduled, if I remember well, for 23rd.
23rd April. So I just add the theme. So it's the économiste, quelle complication économique, quelle gestion de crise. So we are very pleased to have the opportunity to invite 2 professors from University of Fudan in China to give us the next webinar for this experience of international exchange. Okay, thank you.
So enjoy the rest of the day, and maybe the most important, remain healthy, please. Bye-bye.
Thank you.
Yes,
Bye-bye.
Bye. Stay
Thank you.
safe. Bye.